Hello, everyone. Welcome to join our COXO regular weekly webinar. This is our 43rd webinar. This is Bruce hosting this live broadcast. Last week, we had Dr. Victor Nopega from Brazil sharing his topic of how to handle calcified canals with safety, which has given us good instructions and useful directions to our dentist practitioners. This time, we are honored to have invited Dr. Arun Kumar from India to share with his topic, immediate implants, recent trends and protocols. Dr. Arun Kumar is an experienced dental surgeon and prosthodontist and implantologist. By the way, every time during our COXO Free Public webinar, we prepare a certificate for those who join our course, which would be part of your qualifications for your career. Now let me introduce how to get our certificate. There are two steps for our audience to get our certificate. The first step, simply follow and like our COXO page. The second step, leave your comment or question below the live video. At the end of the live, we will share the form link to the comment below the live video. Please open the link and fill the form and submit to apply for the certificate. After these three steps are all done, in 5 days, you will receive our PDF certificate in your email. Please note, the form application can be filled only once and will be available for only 5 hours after the lecture. In 5 hours, the application channel will be closed. After that time, we will not accept any application anymore. Please fill out the form as soon as possible after the webinar. 2. The form cannot be modified. Please make sure the information you left are correct. This is what the certificate looks like. Okay, in the end, I want to remind you that in the webinar, we prepare 2 prizes. One prize is the best question prize. Please leave your questions below the live video. Dr. Arun Kumar will answer your questions and pick up the best one. The person who raised the best question will get 1 piece of color high-speed handpiece. 2. The second prize will be chosen by lucky draw. You need to comment on the video during the live. Then you can have a chance to get our special gift. Okay, now let me welcome Dr. Arun Kumar to come in. Hello. Welcome to give us very useful lectures taking your precious time to share with our dentist friends.
Thank you so much for the opportunities. I'm so happy to be here sharing on the immediate implants. So thank you, COXO, for inviting me. I'm sure that the next 1 hour is going to be very useful for all of us, and we can learn something new so that we can start implementing in our practice right away. Thank you for that.
Okay. Now we leave time to Dr. Arun Kumar for him to start the lecture. Now let's begin. Dr. Arun Kumar, now let's begin.
So thank you once again. Good afternoon, good evening, all across the world. It's been such a pleasure to speak in this forum on the COXO's free public webinar forum, on speaking on immediate implants, recent trends, and protocols is what that we will be speaking on. I'm speaking from Chennai, India. It's a good afternoon here. So I finished both my graduation and my post graduation and then qualified as a prosthodontist, and I've been practicing implants for the more than last 16 years. And I teach. I surgically place implants, I restore implants, and I also teach implants to other practitioners. So that's what I'll be doing. So implant dentistry primarily started as a surgical discipline. So the goal when we first started out on implant dentistry was more of a surgical outcome, right? So it was, can we place an implant that is going to well integrate with the bone, and the implants are not mobile over a period of time, became the category of called the success of an implant dentistry. So, and then over a period of many years, the goal of implant dentistry changed not only from a surgical success, also to a prosthetic success. So what I mean by prosthetic success? So when I mean prosthetic successes, do we not only place implants, we also give teeth on those placed implants in the most ideal location that will be there in the patient's natural dentition. So then the concept became like begin with the end in the mind. First, have the teeth in place. Once we have the teeth in place, how do we accommodate the implant became the goal of implant dentistry. So from a surgical discipline, implant dentistry, it became a prosthodontically driven implant dentistry. So that's how it actually modified over a period of many years. Now, it's no more just a surgical outcome or a prosthetic outcome. Now the focus has become aesthetic dentistry. So now we are not only looking at giving teeth as close to nature as possible, but also making sure that our teeth that we give are almost invisible in the patient's mouth. How closely we can mimic the implant that we placed to the nature has become the goal. So whenever we do implant dentistry, so the goal now becomes aesthetic outcome, followed by prosthetic outcome, and third become the surgical outcome, because now we are redefining the way that we can actually doing implant dentistry. It's very crucial for us to understand these three outcomes, because we're going to speak today on immediate implant, the recent trends and protocols. So when it comes to immediate implants, so now, so it's very crucial to understand how are we going to define the aesthetics, how are we going to define the prosthetics, and how are we going to define the surgical outcome. Only if you're able to achieve all these things, then we do go about doing an immediate implant. So for long-term success of any dental implants, so we are looking at 2 to 4 millimeter of healthy bone that surrounds the implant. We're looking at a 3 mm of a vertical attached soft tissue to keep the bone healthy. And also we are looking at 2 to 3 mm of attached gingiva. So these are some of the commonest, these are some of the well-established protocol for us to achieve long-term success of dental implants. So what do we mean by immediate implants? So we have a tooth that is badly broken down. It can be like a fractured tooth due to trauma, or it can be like a endodontically treated teeth fractured, or a non-restorable teeth. So those teeth we extracted, Like for example, I'm showing a clinical case where we have a badly damaged, fractured upper premolar. So it's badly damaged. So we are extracting the tooth. So that leaves us with an extraction socket. That in that extraction socket, can the extraction socket be filled with an immediate implant? So how do we place an implant immediately in the extraction socket? And then, because not necessarily the defect or the socket is going to be three-dimensionally different from the implant dimensions which we place, we have to fill the defect or the jumping distance, which we call, with bone grafting. So we fill the immediate implant site, not only place the implant, but also place a bone grafting there. Now the bone grafting will help to place will fill up the defect that is there, which will help to close the defect. So once we have placed the bone grafting in place, if it's going to be an aesthetic zone, we are looking at also giving a crown on top of the planned implant. For example, in this particular case, we have done an implant immediately. Once you've done the implant immediately, we have given bone grafting, and also we are giving a provisional crown. So the picture you're seeing here towards the end here is a crown that's been placed on the implant on the same day as surgery. Because it's placed on the same day of surgery, so we are not only giving immediate implant and grafting, we are also giving a provisional on the crown or a temporary crown. So once we do that, then we can always give the final crown. The final crown can either be a cemented crown or a screw retain crown. So in this particular patient, we have given a full digital workflow of a screw retained emax crown that is being given on a tie base abutment. So this is what that has been done for this particular patient. So what I mean by immediate implant is, we have a tooth that is not restorable. How effectively can we remove the tooth atraumatically as possible? How do we evaluate the socket to see whether an immediate implant is going to be possible in that particular socket or not? If there is any infection in the socket, how do we ensure that we will be able to remove those infections completely clearly? And then how do we place those implants? This is what that we will be seeing during the period of the next 1 hour. So when it comes to immediate implant, how can we classify the immediate implant? So there are different kind of classification that is available for immediate implant. So basically, the implants are classified based on the time of extraction, one, and also it is classified based on amount of whether a soft tissue coverage has happened or amount of radiographic bone fill that has happened. So that's how we classify the implant. So now to refresh what we have seen in the first few minutes. So when dental implants are placed in the socket on the same day as tooth extraction, is called an immediate implant placement. Early implant placement, where dental implants are placed with soft tissue healing, which is 4 to 8 weeks time, or partial bone healing, which is 12 to 16 weeks after tooth extraction. This is an early implant placement. Of course, the late implant placement will be the conventional way where we allow the bone to completely heal and then place that implants on late implant placement. Now, when it comes to, we need to understand the difference between an immediate implant placement and an implant loading protocols. So the reason we should understand is, sometimes we might be able to give only the implants. The condition of the bone there might not be suitable enough for us to load the implant immediately. So we need to understand the difference between an immediate implant and an immediate loading. In immediate loading, typically we give a tooth on the implant that we have placed in occlusion with the opposing arch within the first week of implant placement. So that's what an immediate loading is. So we have a tooth that is in occlusion with the opposing arch. So that's what an immediate loading is. When it comes to immediate restoration, typically we give a tooth on the implant, but they are not in occlusion. It doesn't join with the opposing teeth. So they are left out of occlusion. So we need to differentiate between what an immediate implant is, what immediate loading is, and what immediate restoration is. So once we understood this, the other methods by which we can always give tooth are early loading and conventional loading. Early loading, where we wait for 1 week to 2 months time after the implant placement, when we give a tooth or a prosthesis on the implant in occlusion with the opposing teeth, is called early loading. In conventional loading, dental implants are allowed to heal for a period of more than 2 months time after the implant placement to give you conventional loading. So these are a certain differentiating factors which we should understand in when it comes to immediate implant placement and also immediate loading protocol. So when it comes to implant loading, so where we will be seeing it in our subsequent slides, we need to understand based on the patient biologic factors, which is what is the quality of bone the patient has, what is the volume of bone the patient has, and also the soft tissue. When I say soft tissue, what is the kind of papilla that is there, the midfacial gingiva, what is the gingival biotype? Are we going to do a flapless approach? Are we doing a flap approach? So based on these two factors will be the biologic factors. When the biologic factors are favorable and the soft tissue is good, we have a thick biotype, we will be able to do an immediate loading. Also based on the mechanical factors. Mechanical factors will depend on the size of the length of the implant and diameter of the implant, and what is the design of that implant. Is that implant geometry and the surface of the implant, is it suitable for immediate loading? How soon does a bone apposition happens on that implant will determine whether implant loading is possible or not. So whenever it comes to immediate implant placement, we should have a clinical roadmap. So what do I mean by clinical roadmap? The first one, of course, is to diagnose, plan, and assess risk. Because here we are looking not at just a surgical outcome, we are also looking at an aesthetic outcome and a prosthetic outcome, right? So we should be able to diagnose, plan, and assess risk. That is one. We should be able to do an ideal 3D bone level implant placement, check the bone quality and the quantity, check for soft tissue. So these are the most important considerations which we should do before we actually plan an immediate implant. Also, we should always, because today's patients are extremely busy, they are of very high aesthetic demand, we should be able to always give a provisional for the patient to ensure that the patient function is restored immediately. Also, provisional also helps to condition the soft tissues. So now, before getting into the immediate placement, let's look at some of the basic understanding which we should have for a success of any implant placement. So we are looking at an implant that is placed at least 1.5 millimeter from the adjacent tooth roots. We are looking at the implant not only 1.5 millimeter from the adjacent tooth roots, it should also be 3 millimeter from the cemento-enamel junction of the adjacent tooth root. So we are placing an implant that is at least 3 millimeter from the cemento-enamel junction of the adjacent tooth root, 1.5 mm from the adjacent tooth root, and also an ideal implant angulation is one that helps the implant screw channel to come out through the cingulum area of the plant tooth. So we are looking at an implant which is going to come through the cingulum area of the plant tooth. That will be the ideal implant angulation. So before, in the earlier slide, I was speaking about an ideal 3D implant position. Now we are going to look at what an ideal 3D implant position is going to look at. So when it comes to an ideal 3D implant position, we are looking at a labiopalatal position, which is, when I say a labiopalatal position, the implant should come typically at the cingulum area of the proposed tooth. So that's what will be an ideal labiopalatal position is going to be. And then we should also have a ideal mesiodistal position. Ideal mesiodistal position will help us to arrive at the interdental papilla. How are we going to predictably have the interdental papilla that is going to come? So this will help us to define the aesthetics of the restoration. And whenever it comes to placing multiple implants, adjacent implants, it helps us to plan how much are we going to give space between those implants. So that will be the mesiodistal positioning. Also, we'll have the apico-coronal position. It is how far subcrestal should we plan the implant that is going to be placed. So when it comes to apicocoronal position, so this helps us to, so we need to place those planned implant at least 1.5 millimeter to 2 millimeters subcrestal to the extraction socket. I hope you understood the ideal 3D implant positioning, which is labiopalatally, how the implant is going to emerge, where the implant screw channel is going to come out through the cingulum area of the proposed tooth, mesiodistally, which helps us to plan our interdental papilla, and also the apicocoronal position, 3 mm from the simulto-enamel junction, 1.5 mm subcrestal into the. So now, before we progress further, let's look at a video of an implant surgery which is happening. So now, certain critical factors which we should understand during the surgery is atraumatic extraction is the most critical factor. We need to ensure that the teeth are extracted atraumatically and also as minimal flap as possible. Once we extract the tooth, a thorough debridement of the cavity of the extraction socket is very, very important. We need to completely clean the socket of all the granulation tissue, of all the infection. So once we do that, we check the socket for integrity. And if you look at the way that I'm drilling, my drill is oriented towards the lingual. So I am at least 2 millimeters away from the labial cortical plate, the way that I'm drilling. And because I'm also using the lingual bone and the apical bone, I will be able to achieve a good primary stability into the extraction socket. So now here we saw a case where we extracted, completely cleaned the socket, and then thoroughly debrided the socket. Once you've thoroughly debrided the socket, we then use the lingual bone and then place that implant. Now, you will also see me that because we have placed it on an immediate implant, we fill with bone graft. What you're seeing now is a PRF membrane. So this PRF membrane does two important functions. It causes a lot of angiogenesis. It causes a lot of new blood vessels. Because of the new blood vessels, right? So we'll have a lot of new bone growing there. So because of the new blood vessels, and this also serves as a membrane to hold the graft in place. Because it serves to hold serves as a membrane to hold the graft in place, then I can give a provisional crown or a temporary crown on the tooth, which will make it look like a natural teeth. So what you're seeing here is an immediate implant which has been restored with a provisional crown, which helps us to get the best aesthetics as possible. So we saw some of the certain important functions or important considerations which we should follow for us to ensure that the immediate implants are successful. Now, when I say that, so am I saying immediate implants are successful? Is it my personal opinion, or there are enough studies to prove that immediate implants are successful? So let's look at some of the literature that is available, which shows the success rate of those immediate implants, right? So first is immediate implants have got a predictable results. It has been shown that there are several advantages over delayed implant placement. That is one. However, what we need to understand is there are technical complications have been described regarding this technique. So why do I say there can be technical complication regarding this technique? Is because we should understand that immediate implants are typically placed on an extraction socket, where the size of the socket will be different from the type of the implant that we are placing. Because of that, there can be a technical complications which we need to understand. Also, because the size of the extracted tooth is going to be different, we might have to fill the defect with biomaterials, which are bone graft that is required, so that the extraction socket is completely closed and we have good bone forming. So then when it comes to immediate implant, what are the other considerations which we should understand? So when it comes to other considerations, we should understand the crestal bone resorption that is there between immediate and delayed implants. When it comes to crestal bone, how does immediate implant behave when it comes to delayed implant placement? That is one. How the soft tissue is going to be, whether any periapical infection, and how do we graft it is what that we will be looking into it. So it has been shown that using a clinical study using platform switching, immediate implants showed, in fact, reduce crestal bone loss. So it looks like when you do an immediate implant, the crestal bone loss is actually less when compared to a delayed implant placement. So that is the advantage of it. And when you use a platform switched implant versus a non-platform switched implant, studies are variable. Some is favorable for platform switched implant, some are not. Some says similar results. So it has been shown that crestal bone formation is very good. In fact, it is better for immediate implant placement. So the next, once we know that bone is going to be good, the next important thing is going to be the soft tissue outcome, right? How the gums, because we are looking at an aesthetic outcome here. So when it looks to aesthetic outcome, it has been shown that immediate implant placement has got a favorable soft tissue outcome. In fact, immediate implant placement has got a soft tissue growth has happened with immediate implant placement. Also, the advantage of using a platform switching implant for immediate implant is we actually have a soft tissue gain where it helps to do when you do an immediate implant placement. Another important thing is most often when we come for an extraction of the tooth, we are looking at a periapical infection. So for example, you are looking at a video where of an infected tooth where there has been a considerable amount of bone. You can see the entire labial cortical plate is perforated. There is absolutely no bone there because there is completely no bone. So when a periapical infection is present there, it might be difficult for us to place an immediate implant because we might not be able to take out the infection immediately. So it's better that we do a delayed implant placement, because in such cases it has been proven that a gum recession or a gingival recession can actually happen, is more clinically significant in the immediate implant group, right? Then we have to look at biomaterials, right? So when it comes to biomaterials, we're looking at how are we going to close the defect. One is of course an implant, and then what are the grafting considerations. The most commonest graft, of course, the best gold standard would be to use an autograft, but we can use a bovine matrix with collagen membrane is the next most common grafting material that has been used. And it's used when the distance between the implant placed and the labial cortical plate gap exceeded 1 mm. So various graft can be used. Some of the commonest materials that are being used are, you have the mineralized bone allograft is one. I routinely use PRF in my practice. We draw blood, mix it with autograft or mix it with xenograft and then use it. And then we can use a membrane to close to graft, and then we can use autogenous bone chips too. So there are multiple grafting options that are available for us to successfully close. So when it comes to grafting considerations, we can see here the gold standard would be to do something called the autogenous bone graft. In this particular case, where we look at the extraction socket defect is really huge. Because it is huge, there is complete absence of labial cortical plate. Because there is complete absence of labial cortical plate, we will not be immediate implant becomes a very, very difficult in this particular case. So we're doing some autogenous bone grafting, and because we are doing some, and then once we have done the autogenous bone grafting, I'm mixing it with some PRF, some xenograft, and then placing it there using a cytoplast membrane to achieve a predictable bone volume development. So here we are not doing an immediate implant placement. We are doing what is called a site development. So what I mean by a site development is, you can see in the down video that is there, I have placed a titanium mesh membrane, and then where from no bone to abundant bone scenario, we are able to predictably grow bone here by doing a grafting. So once we are able to do the grafting, then what we need to understand is the implant stability, right? So when it comes to implant stability, we can use, during the placement of implant, we can use a resonance frequency analysis and also check the implant, what is the insertion torque. And it has been proven that immediately placed implants, when the initial primary stability has got more than 60 ISQ values, and which has been measured with Austin, they perform in almost the same kind of manner as a delayed implant placement. So to close in the studies, it has been proven that clinical experience has provided the criteria for immediate implant placement success, right? So if you're able to extract the tooth atraumatically, clean the socket, minimally invasive surgical approach, and get good primary stability, it will be able to get a good immediate implant placement. So what we need to understand when it does, in general, in closing considerations for immediate implant placement is, immediate implant placement is generally a more difficult technique because delayed implant placement allowed greater initial stability, because there is also an increased risk of mucosal recession. So in this particular video that I'm showing, you can see me placing that implant immediately, but to get the path of insertion onto the planned area is going to be difficult. So we need to understand that when we plan an immediate implant placement. So immediate implant placement is a viable alternative to delayed implant placement. However, it requires a careful case selection and a specific treatment protocol, because it's very sensitive technique and more difficult to execute than a conventional protocol. So now, how do we go about? So we have understood that it's a technique sensitive procedure, and so it requires a careful assessment for immediate implant. So what are the things that we should assess for an immediate implant placement? One, the smile. What is the display of the smile? What is the soft tissue? How good the bony plate is? What is the thickness of the facial plate? What is the root position when in the CT scan? And also availability of the bone apically for stability, the interdental height of bone, and plan for provisional restoration. So these are some of the things which we should consider to assess the risk for immediate implant placement. So once we have assessed the risk for immediate implant placement, as I said in the beginning of the lecture, it is just not a surgical modality here. It is just not a prosthetic modality here. We are also looking at an aesthetic modality here. Because it's an aesthetic modality here, what are the key aesthetic risk factors? So when it comes to aesthetic risk factors, we should understand the timing of implant placement will be one, the number of implants and the teeth being replaced, lip line, the patient is having a low lip line or a normal lip line or a high lip line, is an aesthetic risk factors. What about the hard tissue volume and type? Interdental height of bone, because this interdental height of bone is very crucial, because it helps us to determine whether will we have a papilla, it is going to be present between those implant and the natural teeth or not. And also what is important is the soft tissue volume and type. What is the type of gingival biotype? Is a thick type phenotype or a thin type? Also is very, very important. So once we have identified, we have diagnosed and treatment plan, we have identified the key aesthetic risk factors. Now we have decided that we will go ahead with the immediate implant placement. Before doing the extraction, we need to assess the socket, or how is the radiographic assessment of the root position. That is one important criteria which we should understand. So once we do that, the second important criteria is the actual socket after integrity. So we have diagnosed and treatment plan, and then once you have diagnosed and treatment plan, we have identified the aesthetic risk factors. And once we have identified the aesthetic risk factors, before we actually do the extraction, we need to assess the radiographic assessment of the root position. And then after we do the extraction, we need to assess the socket. So when it comes to radiographic root position, it has been proven that as long as the facial bone thickness is greater than 1 mm, then the amount of vertical resorption that happens after immediate resorption is very less. But when the facial bone thickness is less than 1 mm, we are looking at a vertical resorption as much as 7.5 mm in thin wall phenotype when compared to thick wall phenotypes. So this again is a CT finding. So in the CT finding, in a cone beam computerized computerized tomography, we check the thickness of the facial plate and then decide whether it is greater than 1 mm or less than 1 mm is what that we look at. The next important criteria is the radial root position. So what I mean by radial root position is, so now how is the root of the plant of the tooth that we are going to extract into the socket. So we can then determine this as class 1, class 2, class 3, class 4 and class 5. In a class 1 is the tooth is centrally positioned within the ridge, whereas in a class 2 the tooth is retroclined. In a class 3 the tooth is proclined. So based on the different radial root radial plane tooth position, we can, what you see in the down picture, we have the radial root position is the blue line. The purple line, it will help us to evaluate based on the tooth position what will be my primary drill sequence. How am I going to drill my primary drill? So it will vary from different root position. So this will, before we actually do the extraction itself, we are first determining how simple it's going to be or how complex it's going to be. For example, if it's going to be a class 5 radial root position, thin facial and palatal bone walls, we will not be able to do an immediate implant in that scenario, where we might have to do a socket grafting, site development, and then only do a delayed implant placement. So this helps us to identify whether immediate implant placement is going to be possible or not. The next important criteria is it's called EDS, or the extraction defect assessment, where now here what we do is we have extracted the tooth. Once we have extracted the tooth, we know how the radial root is. Now we are going to assess the socket. So when you are assessing the socket, we can classify the extraction socket as 1, 2, 3 and 4, where based on the biotype, we call it as an extraction defect socket. 1 is pristine, where there is a 0 mm of hard tissue loss and a thick tissue biotype is there. Extraction defect 2, which is pristine to slight damage, and extraction defect 4 is a severe damage. So now, based on how the extraction defect is, whether it's 1, 2, 3 or 4, we are looking at either doing an immediate implant in EDS 1, or in EDS 4, we might have to do just a site preservation, site development and place implant laterally, right? So this helps us to have a guideline and how do we go about doing the immediate. So it's not that for every patient we can do an immediate implant. So we assess the aesthetic risk and then determine whether it will be a good case to do an immediate implant or not, and then we proceed. So now, how do we go about the case selection? We are looking at an atraumatic extraction. The socket has to be intact, an intact socket, preferably a single rooted teeth. There should not be any infection there. The biotype, it has to be a thick tissue biotype. Tooth form has to be a rectangular tooth form, low lip line, interproximal height of bone 5 mm from the contact point. So this becomes the critical factors in which how do we select the case. So now once you have selected the case, we are ready for immediate implant. We have seen the diagnosis and the treatment planning for different cases, right? So once we do that, so how do we sequence it? Now, is it something that based on our individual thing, right? If you are new to implant dentistry, we might not. So based on our skill and experience, we have to determine whether are we going to do an immediate implant or not. So that will be the first thing. So then we select the case. Then we always do a CBCT scan and a treatment planning. For example, in this particular CT scan video, we are looking at a root that has been fractured, but there are 2 roots there. How are we going to place that implant in this particular tooth? So, we do that. So once we do that, we know our skill and experience, then we select the case, and then we do a CBCT and a treatment planning. So when we do a CBCT treatment planning, we can do a virtual planning of the implants, take the CBCT data into a virtual design studio, design your implant. So if you want to be very predictable, you can do like a surgical guide, or you can do freehand. In this particular case, you have seen me designing the implant and then doing a freehand surgery, which will help us to place the implant in the planned position. So once you have done it, the next step is we identify whether are we going to do a flapless surgery or a minimal flap surgery. That's very, very critical. Then we are looking at an atraumatic extraction and the use of lingual and apical bone to place that implant. So you're looking me during the video where we have cleaned the socket. You will see the drill. When I'm drilling, it's almost 2 millimeters away from the labial cortical plate, and I'm engaging the apical bone and the lingual bone for me to do the implant. So that's what we are doing here. And so that helps us to achieve good primary stability and tendon. So the next important criteria there is, after we have used the lingual and the apical bone, we need to understand that how are we going to do a site preparation or an osseodensification. For example, in this particular slide series that I'm showing you, so we have a tooth, a premolar tooth with buccal root and the palatal root. You have seen me, we have done an atraumatic extraction. I'm slowly doing an osseodensification, expanding the palatal root, and then once I have expanded the palatal root socket, the socket of the palatal root, I am placing an implant. So if you can look at my the palatal root width, and then I'm placing almost like a 4.7 diameter wide implant into the palatal root socket. So this is how we do the implant design, and we do an ideal 3D implant positioning is done. So once we do the ideal 3D implant positioning, then the most important critical factor will be to evaluate the implant stability. So we can, of course, measure the insertion torque. So once we do the insertion torque, we check for the implant stability. Then we graft there. You can see me here. I'm using like a xenograft PRF mixture. You can see me using a membrane to hold the graft in place. We are doing an immediate implant there. You can see the implants being placed. And then you use a membrane to stabilize the graft as appropriate, and then either do a single stage protocol or a 2-stage protocol, right? So then what I mean by a single stage protocol is do the healing cap immediately. If it is going to be a 2-stage protocol, you place only the cover screw and then do the healing cap subsequently as the 2nd stage surgery. So that would be that step. And of course, then would be the sequencing. The sequencing, we are looking at the soft tissue procedure. How are we going to do the provisional crown, and then emergence profile modification. So when it comes to immediate implant, I would always prefer to do it as a single stage procedure. Once I do it as a single stage procedure, I can customize my healing abutment, and I can I can use my healing abutment to have my emergence profile developed there. So that's what I'm doing now. So this becomes the sequence of an immediate implant placement. So when we customize that immediate implant, what we need to, the healing cap, sometimes the healing cap, when I can use a composite on the healing cap, and then to modify the emergence profile. So there a word of caution there. It's very crucial for us to understand so that the composite doesn't impinge on the soft tissue and then get impacted into the soft tissue. And so that's how we are able to modify the emergence profile for this particular patient. And once we have modified the emergence profile there, then I can go ahead and restore the implant as a one-visit screw retain implant restoration. So where we are able to do a complete sequence of getting a screw retain crown on the implant. So that's how we are able to complete the implant sequence for that particular patient. Some of the additional considerations which we should understand, especially when it comes to the aesthetic aspect, is whether should we do an additional soft tissue surgery or not. When are we going to do the final restoration? Is it going to be an early loading or a delayed loading? And what about the radiographs? Radiographic assessment. So when it comes to the immediate implant, there are certain techniques which are used in the aesthetic zone which we should understand, so that we have more than one particular technique for us to place the implant. So we have, for example, something called the dual zone technique, where we not only place immediate implant and then graft it to the bone, we also graft the soft tissue. So depending on the interdental papilla, the soft tissue, we can plan a dual zone technique, or we can do what is called a surgical veneer grafting, where we can use a connective tissue graft. A partial extraction therapy is also very commonly used now, where especially on a non-mobile teeth, an apex removed and remaining length is about 8 mm, we can always do a PET surgery. So these are some of the techniques that can be used in the aesthetic zone for us to have a predictable implant for an immediate implant. So once we understood that, so now let's go through the sequence. So we have, how do we go about doing it? So we saw the sequence. So we have a tooth that is badly damaged. In this particular case, we have a molar tooth. So where I'm placing my primary drill there to go between the two roots to do the primary drilling there. Then I'm extracting and I'm placing that immediate implant there. And once I've placed that immediate implant, I need to graft the socket. I need to graft the site where I will be using my PRF mixture, a PRF xenograft mixture to fill the defect size. And once I have filled the defect size, I can always modify the healing collar. So also in my practice, what I do is I also not only do place implant, and I also do grafting myself. I also restore implants. We have a fully digital CEREC workflow in our practice, where we'll be able to do like a 2-hour, 1-visit screw retained zirconia crown or an EMAX crown on the implant. So for this particular patient, we are able to do a 2-hour workflow where not only implants we restore on a modified emergence profile when we are able to complete the implant placement. So that's how we do. So now, since we understood the technique, we have understood the diagnosis and treatment planning, what are the basic criteria for us to ensure aesthetic we have seen. Also, we have understood that. We have seen some cases how we go about doing immediate implant. Next is, can we have some immediate implant? What are some of the guidelines that can be used? So can we have like a simple workflow, like a simple flow chart, which will help us to plan immediate implant when we have a patient walking into our clinic? Can we have a simple flow chart which will help us to identify whether can we do an immediate implant there or not? So we can have it based on the socket type, soft tissue biotype, implant positioning, dual zone grafting, and immediate or delayed provisional. So based on the socket type, so we can determine the implant based on 3 different types of socket. We can have like a type 1 socket, type 2 socket, or a type 3 socket. A type 1 socket is one where the facial bone plate is intact. A type 2 socket is one where the facial bone plate is missing. A type 3 socket is not only facial bone plate is missing, we also have a soft tissue missing. So when it comes to immediate implant placement, a type 1 socket will be the most ideal socket for an immediate implant placement. Type 2, type 3, we are looking at a delayed implant placement. So then we are looking at a tissue biotype. We can determine the tissue biotype as thick biotype or a thin biotype. So when I say a tissue biotype, when you have a thick biotype, immediate implant placement, the unprovisionals can be given when the primary stability is greater than 35 Newton centimeters torque. When the patient is having a thin biotype, immediate implant placement is possible, but we might have to do a delayed provision. So that is one. The next is the implant positioning. Initially, during early in the lecture, we spoke about ideal 3D implant positioning. So it is very important we have a 3D implant positioning, preserve as much of existing soft tissue as possible, do like a minimal flap procedure, and then with a thick biotype, we'll be able to do an immediate provisionalization that is based on the implant positioning. The 4th criteria after all those 3 will be the dual zone grafting. So when it comes to dual zone grafting, we are looking at not just bone, but also soft tissue preservation, right? And dual zone grafting simply means that we not only graft the bone, we also graft to the soft tissue. So the extraction socket will automatically hold the bone graft in place. Also, the provisional can also hold the graft to the soft tissue. So this is also possible. The next is, how are we going to give a provisional? Are we going to give an immediate provisional or a delayed provisional? So depending, if we have greater than 35 Newton centimeter torque with a thick biotype, we will be able to do an immediate implant placement and immediate provisional. So a simple flow chart which will help us to understand this. So when you have a type 1 socket with an intact buccal plate bone, no soft tissue loss, thick gingival biotype, we'll be able to place immediate implant, place them 2 mm away from the buccal cortical plate, 1 mm subcrestal, do a bone grafting, dual zone grafting, and also do give an immediate provisional there, where, and if the primary stability is greater than 35 Newton. So this is a simple flow chart which helps us to understand whether an immediate implant placement is possible or not, right? So in a type 2 socket or a type 3 socket, we don't plan an immediate implant placement. So now that we have know the this work chart, so we should also understand what can happen if we don't follow the guidelines, right? So this is again a case where I'm showing you a surgery that has been taken while doing an immediate implant. So the patient lost both the central as well as the lateral incisor. You can see the complete absence of labial cortical plate. Because of complete absence of labial cortical plate, you're seeing that it's almost impossible to do an immediate implant case in this scenario. But for various patient considerations, I went ahead and then did an immediate implant for this particular patient. You can see the amount of thread exposure there on both the implants, right? So most of the threads on the lateral incisor implant is visible. Almost like 6 threads on the central incisor implant is also visible. So in this particular placement of implant, then what happens is it becomes very difficult to achieve primary stability. So in this particular case, what we need to understand is I used a hand wrenching tool or a hand torquing tool for me to place that implant in place. So during the surgery, you can see me using a hand torquing tool. The hand torquing tool will help us to place that implant in a very ideal, good location. So I'm using an implant which comes with an implant transfer and impression transfer. You are actually seeing me use a hand torquing tool. Because I used a hand torquing tool, I'll be able to take the implant and then place that implant with good primary stability. So that's what I'm doing right now. And then once we do it, because this particular patient had a complete absence of labial cortical plate, and because we did a complete absence of a labial cortical plate, we are doing like a 2-stage approach where we just put only a cover screw. We have done a dual zone grafting. Because we have done a dual zone grafting, you will see that a lot of bone graft particles getting exposed to the graft, and then we are doing like a 2-stage procedure, right? We are exposing, putting healing caps. Then what I'm doing is allowing the healing caps to completely settle in the bone. Once you have allowed the healing cap to completely settle in the bone, then what happens is we are using provisionals to grow the interdental papilla. Once you have used the provisionals to grow the interdental papilla, then we are able to complete this particular case. So if you can look at the CT images, during the surgery, you saw there was 0 cortical plate of bone, but we are able to predictably grow the cortical plate of bone here. So the healing was very, very adequate for this particular case. But what we need to understand is when it comes to when there is no cortical plate, some of the key takeaways which we should understand for that particular cases, when there is no cortical plate, to arrive at the vertical positioning of the implant is very, very important. How do we overcome deficient anterior maxilla channels, dual zone grafting, soft tissue procedures, and how are we going to do a lab thing? So we have seen some implant loading. What is immediate implant we saw? what is immediate loading protocols also we have seen. So once we know that, however, there is a simple classification which we can follow when it comes to immediate implant. So this is based on the latest ITI guidelines, that is their ITI consensus statement of 2018, where they have classified immediate implant, early implant, and delayed implant placement. So when it comes to immediate implant, they're classifying it as type 1A, B, and C, where 1A is immediate implant plus immediate restoration, 1B is immediate implant plus early loading, 1C is immediate implant places conventional loading. So when it comes to type 2 and type 3, type 2 we are looking at an early placement with soft tissue, and type 3 we are looking at an early placement with partial bone healing. So these are the different kinds of type 2 as well as type 3. When it comes to type 4, so we have looked at what is type 1, we looked at what is type 2, we looked at what is type 3. When it comes to type 4, we are looking at a late placement. What I mean by late placement, we are looking at a more than a complete bone healing to happen, and then we are doing a type 4 placement, which is A is immediate late placement, immediate restoration, late placement, early loading, late placement, and conventional loading. So now when it comes to it, how do we determine success? So how can we have success? So when it comes to, it has been clinically proven that 1A, which is we are doing an immediate implant placement plus immediate restoration, is a clinically documented protocol. But when it comes to 1B and 1C, it's a documented protocol. And if it's 1C, which is immediate implant placement and conventional loading, it's a clinically scientifically valid protocol. So we are looking at success of the restoration here. So when it comes to immediate implant with immediate restoration, it's clinically documented well. There is enough documentation. When it comes to immediate implant and late loading or a delayed loading, it's a valid, scientifically valid protocol. So when it comes to 2 and 3, both A, B, and C, there is only insufficient clinical documentation that is there. Of course, with a delayed conventional loading, we have a clinically valid, scientifically valid protocol. The last aspect of the consensus statement is type 4A, B, and C, where in 4A, which is early placement with immediate restoration, is a clinically, again, a documented protocol. 4B is also a scientifically and a valid protocol, and 4C is also a scientifically and a clinically valid protocol. So we are coming towards the last 5-10 minutes towards the end of the lecture, where I'll show you like a video. In this particular video, we are doing immediate implants there. We are looking at a 2 premolar scenario, adjacent tooth scenario, where there is, because of an infection, there is an active sinus tract there with active pus discharge. So because of active sinus tract and active pus discharge, there is absence of labial cortical plate. So first we are doing like a CT treatment planning. Once we have done a CT treatment planning, then we are doing an atraumatic extraction. And then once I do the atraumatic extraction, I use a piezosurgery, piezotome, to do an atraumatic extraction. So once we do the piezosurgery or a piezotome to do the atraumatic extraction, we clean up the socket of all the infected tissue. You can see the amount of granulation tissue that is there. All the granulation tissue is being completely taken off. So once we have completely taken off, you will see the drilling protocol. I'll be drilling using my lingual bone and the apical bone. My drill is always 2 mm away from the labial cortical plate, because it is 2 mm away from the labial cortical plate. So we are preserving as much as labial cortical plate of bone as possible. So once we have done it, so we'll be able to place that implant with adequate primary stability. Once we have placed that implant with adequate primary stability, you can actually see me actually placing that implants with adequate primary stability. And then what we do, now there is space that is there. The jumping distance has to be filled with bone. So now you can look at the implants there. It is well away from the labial cortical plate. You can see the implants that is exposed labial cortical plate dehiscence. So then we fill this area with a bone grafting material. Once we fill it with bone grafting material, we can always put a PRF membrane there, and then put a collagen membrane there. Once we put a PRF membrane, collagen membrane, we put sutures, and then we'll be able to close it. So once we have, so this You can see the bottom pictures. I'm showing you CT scan post-healing. The CT scan post-healing shows a very good amount of bone healing that has taken place. So that's how we complete that particular case. So what are some of the benefits? We are looking at an immediate implant benefits versus risk. So when you're looking at benefits versus risk, immediate implants has got a reduced treatment time, reduced number of surgeries, post-extraction bone loss is also less. Soft tissue preservation can happen if you follow all the protocol. The risk is to get the primary stability is a challenge. We can always say movement of implant towards a buccal can happen. Gingival recession can happen. Buccal penetration and primary closure is also difficult. So the next important criteria when you do an immediate implant is something called the immediate provisionalization. So what I mean by immediate provisionalization is it's very important. Not only we place an immediate implant for the patient, can we also give an immediate tooth on the patient? So now you look at, in this particular case, it's a canine tooth where we have extracted and placed that implant there. Once we have placed that implant, we are giving an immediate provisional. And what you see in the bottom picture is my provisional is as close to my ceramic tooth also as possible. So here, the provisional not only helps to hold the bone graft in place, it also helps to soft tissue conditioning and hold the papilla in place. So that's what is happening right there. Once we do that, then we can always do the final restoration. I would prefer to go use for the final restoration, also the provisional restoration, a fully digital workflow. So what I mean by a fully digital workflow, I use a CEREC workflow. So I use typically a tie base and then I place a scan post on the tie base. I scan my implant and then digitally restore the tooth. So that's all I would do. I do a complete digital workflow is what that I do. So this digital workflow does two things. One, it reduces the time. It gives a very predictable restoration and also helps me to give a crown in a screw retain crown in probably just a 2-hour workflow is what that helps to do. So once we have the crown ready, then we can always use an extraoral bonding protocol to bond the crown to the tie base. Once we bond the crown to the tie base, we'll be able to use a cemented either a zirconia or a Emax crown and then use a single workflow to fix the crown to the patient's mouth. So that's what we'll be able to do it. We will be able to do give a single workflow to do it. So we're coming to the end of the presentation here. So once we have understood the different aspects of immediate implant, if you have any questions, I would probably suggest you to ask in the comment section below. So and then I will be able to answer the questions whatever you have, either with regards to immediate implant, with aesthetics, with restoration. I'll be happy to answer your questions here. In summary, we understood that immediate implants can be a successful treatment option. We can use ridge, socket expansion, osteodensification to improve outcome. We need to have a good graft material to increase our predictability. Soft tissue procedure needs to be done, and also use of digital workflow will help us to have a greater precision and ease of work for greater success. And with this, I thank COXO for this wonderful opportunity to come and meet you in this afternoon and this evening to speak on the immediate implant. And it's been a very, I hope the presentation was very useful for you. Thank you, and until we see you next time, bye-bye, and a very, very good evening to you. Thank you so much.
Hello, Dr. Arun Kumar. Thanks a lot for your wonderful lecture. We hope we are sure our dentist friends have gained a lot of useful knowledge and useful skills and experience from your lecture. How many questions coming in? How many questions have?
I think there is a question on socket preservation
Yeah.
How do you sort of implant placement
Yeah.
as the best success rate? If there is no,
It's for you. It's for you to pick out the best question
okay,
for you to
all
decide.
right. So I have okay, and then someone has asked about the platform switch implant, the torque of the physio dispenser, and somebody asked which is a graft for the good material. So I would be, and then there is another question: did you use PRF membrane and collagen membrane simultaneously? So I would probably, the best question I would pick up is which is the graft material that is the most suitable for immediate implant. So that would be the my choice of the best question. I hope so that would be the best question. Can I answer that question now?
Okay. Now, have you answered the question?
I'm going to answer the question right now.
Yeah, please answer the question respectively.
Right. Okay. So the first question was socket preservation and the implant or immediate implant. So my choice would always be to first assess all the aesthetic risk factors that are there. Once I assess all the aesthetic risk factors, I will do a CT planning first. In the CT planning, I will determine what is the thickness of the facial cortical plate, and then what is the amount of bone that is there, apical and the lingual, to my to the planned extracted tooth. And then I will do an atraumatic extraction. And when I do an atraumatic extraction, and then I will assess the extraction socket defect, and then I will my first choice would always be an immediate implant placement. So that would be my first choice. When in any of these factors, if there is going to be difficulty or challenges, then only I will go for socket preservation. I hope I answered that question to you. So that was my first. That's the first question that I answered. The second question a viewer has asked about: what is the platform switch implant? So, okay, so what I mean by a platform switch implant is an implant typically has got a threaded design, which will either be a parallel wall or it can be a parallel or a tapered cylinder. The parallel or a tapered cylinder has got a prosthetic platform. So we have an implant diameter and a prosthetic platform. The prosthetic platform, depending on the type of implant, will either be an internal X or a conical connection. We can have a different kind of a prosthetic platform. Now, this prosthetic platform will have a corresponding abutment which goes and sits into the prosthetic platform. So now, when we have a prosthetic platform, say for example, which is say 3.5 diameter prosthetic platform, and we have an implant abutment diameter which is also 3.5 dia, then we call it a platform matched implant. So when I have a prosthetic platform of an implant which is say 3.5, for example, and an abutment prosthetic platform which is say 3 mm, it means that my abutment prosthetic platform is narrower when compared to my implant prosthetic platform. So this is called a platform switched implant. So prosthetic platform, when it's a platform switched implant, it helps us to have a better soft tissue profile and a better bone profile. So that's what we mean by a platform switched implant. I hope I answered that question. The third question was torque and the speed for the physio dispenser for implant placement for pilot drill and implant drill. Typically, we use 1:20 reduction gear handpiece. 800 to 1200 is the speed of my drill. Towards 1200 will be for my pilot drill. Towards 800 for the lateral drills. So this would be my for the speed, and also the torque will be typically 1:20 handpiece, 1:20 reduction gear handpiece. Torque for placement of implant, I'll keep it at 35 and then place that implant. I hope I answered the next question. The fourth question is, which is the ideal graft material? So the ideal graft material, so it's a very important question. It's a very good question. So I'm choosing this ideal graft material as the best question for this lecture series. So the ideal graft material, I would prefer the gold standard will be an autograft, but based on the labial cortical plate, whether it's going to be intact or not, you need to choose an autograft material or an allograft, which can be placed to cover the jumping distance. And as a sandwich on top of the labial cortical plate, they can always place a xenograft and then use a membrane to close it. So an autograft xenograft membrane mixture, which can be used as a sandwich, would be the best graft material of choice. I hope I answered that question. So this gets the best question answer. The best question prize. The last question is, the question was asked is, did you use a PRF membrane and collagen membrane simultaneously? The answer is yes. They can safely use both PRF membrane and collagen membrane simultaneously, no problem whatsoever. PRF membrane will resolve in three weeks time, gives angiogenesis growth factors. Based on the collagen membrane, it has got 3 weeks to 3 months resorption time. So that's how we can use. So that completes all the questions. Thank you for the opportunity.
Okay, you're welcome. Now, please, we'll come to our next step. It's our lottery time. So let's see who will be the lucky person to get our special gift. Today, our special gift is one piece of our high-speed handpiece. Now let me count down. 3, 2, 1, start. Oh, congratulations.
Congratulations.
You are lucky. We will contact you after this webinar. For those who haven't got any prize, don't worry. We will continue to do such kind of activities in our coming webinar. Please actively participate in our live courses. Thanks a lot again for Dr. Arun Kumar taking his precious time to give us such a meaningful and instructive lecture. Don't forget to fill in the form for the certificate, right? By the way, since our company will participate in Dental South China 2022 International Expo, our regular webinar will be postponed to March the 7th next time. That's all for today. Till we meet again. Bye-bye. Finished.